populations. Hello, everyone. Welcome back. I'm really excited to have Craig Rodriguez Sayas to talk to us about how to use HiTop with diverse populations. And this was a topic that came up a few times yesterday, and we didn't have much time to address some of the questions. And we kind of mentioned yesterday that this would be a good time to ask those questions if you still have them. I know it's an issue that's important to a lot of people. We get a lot of questions from this from students and everything as well. So with that, I'll turn it over to Craig.
Ooh, hi, everyone. Can you all hear me well? There we go. All right. So I'm going to talk a little bit about how I think through using HiTop, I suppose, with diverse and underrepresented populations. And I'll just give you a brief overview. So we're just going to talk a little bit about the background and kind of epistemology of our field and the HiTop model, I would say, how they're kind of connected. And this is based on some work that I've been doing with colleagues as part of the DEI work group within HiTop, where we've been looking through the literature of what's kind of underlying the HiTop model and what specifically for the populations that I tend to think about or that aren't usually represented very well. I have a very small, just a minute and a half video on intersectionality. And I think it's important to play because a lot of the thinking through what I'm going to talk about comes from, or I shouldn't say comes from, is related to this kind of critical way of thinking about structures and how they impact people's mental health and how it then kind of proverbially queers the HiTop model interpretation of it, I should say. And then I have two case discussions, which are going to hopefully be participatory, I'm hopeful. They're examples that are loosely based on clients I have seen that were seen prior to there was not using a HiTop domain or the digital assessment tracker tool that we have. Instead, I kind of translated them and what would have come up in an initial assessment based on the information I would have had, and then how that could be complex or nuanced based on thinking about the structures that impact those folks. So my goal is to challenge and maybe consider how context proverbially queers the understanding and use of the HiTop model for, I forgot to highlight that, clinical planning and intervention. How I kind of come to this, just a little bit of, born and raised in the Caribbean, so I'm an immigrant here in the US. Most of my training is primarily with evidence-based interventions for sexual and gender minority populations, so LGBTQ plus folks. And I think a lot of it then is based upon thinking through environmental structures, which slightly differs from the modal way of thinking about psychopathology, at least in psychopathology research. I think it maps onto a lot of the ways that clinicians and we kind of think about the different factors that impact any individual client. But it does provide, I think, some unique ways of looking at the HiTop model or thinking through the HiTop model. And also understanding it's a model, like all models, they're not going to fit perfectly for every single individual, but we can use them for making hypotheses and kind of testing some things. So, and hopefully this will make sense, kind of building off of what Stephanie and Chris kind of talked a little bit about, because I do reference some of those broad suggestions about what types of interventions seem to work best with certain types of spectra. Okay. So this is generally the model we're going to start. We're all kind of used to it. The idea is this interpretable phenotypic hierarchy that kind of gets more and more greater resolution as we go down the chain or up, depending on how you want to describe it. And I would even argue that a lot of the, as Stephanie and Chris have talked about, a lot of the interventions we use are broadly transdiagnostic and work at these kind of spectral level and even the pseudo-spectrum level. Now, to first start, kind of the more, I guess, lecture bit, the HiTop model, and I think as the consortium kind of sees it, is pretty agnostic to the causes of psychopathology and mental health challenges among individuals. It's more a descriptive approach of how symptoms, things tend to co-occur together and using that to kind of draw inferences, to test certain things, to chart more research and even intervention thinking. One thing to think about though is how the dominant norms within psychopathology research impact anything we do. So this is not exclusive to HiTop. This is across all of clinical psychology, I think, and particularly the clinical science type of models, where quantitative methods are privileged. How that becomes an issue is that a lot of the research on underrepresented groups don't always subscribe to this quantitative method. They usually use more mixed methods and sometimes qualitative approaches. So if quantitative methods are preferred, that literature gets kind of erased or left out, which has implications for how we develop a model and who it applies to. Psychopathology is usually considered from intra-individual dysfunction. I don't think it's explicitly said, but a lot of our models, when you look at the early instantiations of the DSM, the language is really that kind of neo-Kreplinian approach, which is something internal to the person has gone awry in the normal developmental process. And that is the results in psychopathology or mental health challenges as we think of them. I don't think that always falls or that always holds when you're thinking about groups who are minoritized and marginalized in different ways based on structures within society. Dominant populations are typically represented. So we have usually cisgender, most of our literature is based on cisgender, heterosexual, white, weird, Western, educated, industrialized, rich, democratic populations. And then there's this assumption of universality, which I think a lot of us try to do. The goal of the High Top Consortium is to create a fully quantitative nosology of psychopathology, one that generalizes to most populations or across all populations. When you think about what literature gets included or what populations get represented, the question is, how universal is this actually? And some of the literature we've been reviewing as part of the work group is that most of the, actually, I think that's in the next slide. Yeah, sorry. So questions to think about is, who could this hold? For whom does the High Top model typically hold? What populations contribute most to the research that undergirds the model and then undergirds our way of thinking about it? Assumptions of generalizability and universality. What are the implications for treatment specifically when I think of that? And how could environmental structures then influence these behaviors or indicators? And I focus mainly on that part because working specifically with LGBTQ plus populations, I was trained, I should say, and this is the approach I subscribe to, that it's impossible not to think of the structures more than anything else in a really, really fundamental way of thinking through psychopathology or challenges folks experience. Okay. Now, the philosophy on ITOP is that the model is supposed to evolve as research evidence kind of exists. So as we get more evidence, we're able to evolve this model in a way so it can incorporate quite a bit of novelty and probably even pluralism to some degree about certain populations. At this time, the model is based exclusively on quantitative evidence. And remember I mentioned earlier, and this is something we've been making an article we're finishing up right now about how the high-top model applies to diverse underrepresented populations. Now, when you look at the research into the high-top canon, and I'm going to get to the intervention part soon, is that there's a lot of cross-national generalizability, or you can assume that there's a lot that kind of went in that looked at these high-top domains across different populations across different countries. So we can kind of feel pretty confident, at least about that, and especially the internalizing and externalizing factors. The others are still slightly less evidence out for. The internalizing and externalizing factors, and to a lesser degree, the thought disorder factors or spectra, are pretty invariant across groups. So a lot of the research has looked at sex assigned at birth, showing that, yeah, these factors look the same. And then the differences in prevalence of specific disorders or disorder categories are related to differences at the factor level or spectral level: age, ethno-racial group, sexual orientation. So there are a few studies that have done that. Only a handful of about 4 or 5 studies, I believe. It's definitely less than 10. I think about 5 if I'm being generous, have looked at how psychosocial stressors are related to these factors. So things like discrimination, rejection sensitivity. And I highlight those two because those are 2 very important structural domains or social domains that I think about when I'm working with LGBTQ plus populations. We've even gone as far as to kind of suggest that the high-top model could be particularly helpful in understanding mental health challenges, and at least from research, but also from an intervention standpoint, related to sexual and gender minority folks. Indeed, when you think about LGBTQ plus populations, and I have an example I'm going to bring in later on. I think David's going to email y'all the slides I have right now, as well as an article that I think really encapsulates a lot of what I'm talking about, is that evidence-based interventions geared towards sexual and gender minority folks are often very trans-agnostic. They map onto what we would be thinking about in this high-top domain anyway. So these are just some figures that I'm pulling out here, and I'm just going to grab a pointer to just go through 1 or 2 quick things. Our typical way of researching and thinking about psychopathology might be that some stressor like discrimination is related to any specific disorder category domain. Our argument instead is that when you look at things like Model C, is that these stresses might be related to the spectrum level and then manifest as these different disorder categories, but that's not the important piece. It's more the spectrum level, consistent with that high-top domain. And then when you consider the multitude of structural and social factors that affect marginalized groups, you can consider them, or you might argue that they act at this spectrum-specific domain. Or you might even study them, and this from a research standpoint, are any specific factors or social stressors related to the spectra or maybe a specific disorder grouping. So perhaps like discrimination is really specifically related to social anxiety, which would make sense. It's a very social aspect. In addition to that broad internalizing kind of psychopathology spectrum, and you can think for intervention, I might, think of broad internalizing based interventions, and then particularly molding them for social anxiety type of presentations. So this is just a brief video that I'm gonna play. It's only 2 minutes, but I think it's important to think through because it provides a fundamental kind of framework for thinking through these structural factors. So it's not gonna take too long. Well, I guess we'll skip the video. It's, would have been nice, but we don't have to get through it. If you're interested, it's just a 1.5-minute video, but thinking through the construct of intersectionality, which I think applies to, descended from Black feminist scholarship. Not even scholarship, I shouldn't say, because it's not descended from the academy, but understanding how these social structures mutually impact and interact with one another and relate to outcomes we think about. And I think about outcomes in the mental health domain. So, okay, high-top model and intervention. I assume that kind of what had been broadly discussed in the previous meeting or workshop, I should say, was thinking through these broad kind of ways of looking at ways of intervening that might align with certain different spectra. So, for somatoform type of related psychopathology, you might think of interoceptive and exposure and response prevention. Thank you, Patricia. That's, I think you put the link inside of there as well. Internalizing type psychopathology, usually exposure and response prevention type of interventions. So you can think of things like social anxiety. It's pretty much what we do quite often. Thought disorder, cognitive restructuring, and some behavioral experimentation. That's much more outside of my expertise area. I haven't worked with many clients with that type of domain, so I won't be talking a lot about that. But then thinking about the externalizing domain, disinhibited externalizing versus antagonistic externalizing. Oftentimes thinking about motivational techniques for disinhibited behavior, for getting people to kind of be on board with changing behavior and maybe aligned more in their values or what they care about. It's funny, I jumped in just to hear the question about to Chris about ACT, and I was thinking to myself, I've been asked if I'm an ACT-based therapist. I've had some specific training, but I don't think of it like that. It's just kind of more how I think broadly in a CBT kind of mindset. Antagonistic externalizing, thinking more about social skills type of training, and then detachment and social withdrawal, more behavioral activation. So the question that comes up, and this is kind of where we're gonna hopefully spend most of the rest of our time, is when thinking about using the high-top or any system. So we're talking about high-top today, but I think this would apply anywhere we go for clinical work. How does context matter? But we can think of, I have 2 clinical examples. So let's look at one case, a 24-year-old guy, and this is pretty much what's showing up in his high-top profile. So we're seeing elevated T-scores on the high-top digital assessment tracker in the following domains. The broad distress type of domains. So I pulled a couple example items that you might see showing up. General depression, things like I feel very hopeless. Dysphoria, I cry every day. You're getting fear, especially in that social anxiety domain. I'm so worried what they'll think of me. Negative emotionality, so affective lability. Anxiousness, relationship insecurity. So we're seeing that interpersonal kind of flavor as well. Excuse me. And detachment, so social withdrawal. I suppose my question that comes to you all, the first kind of bit, is what sort of contextual information would you like to know about this case? Suppose you're just given this high-top profile, what do you think would be important to kind of figure out? And I'm assuming this is kind of where I'm opening up for you. I'll drop it in the chat, just whatever comes to mind. What do you want to know more about as you're thinking about intervention planning or thinking about the interventions we've talked about for the high-top domains? What would you care about right now? So I'll kind of turn it over to attendees, please. Right, so Sean saying situation that precipitates these symptoms. What's the person's social location? Okay, that's a good one, actually. John saying what triggered the recent kind of past 2 week symptoms to be elevated. Cultural group membership. What's their social support like? These are all great things we think about. Yeah. The context relates to fear. I like this one, Caitlin. Thank you. Who is they and who are they and what is he worried about? Okay. What are the contexts in which social anxiety arises? Yeah, these are really, really great ideas and really great kind of, I guess, discussion points. So, yeah. So when we're thinking about these, just this broad domains, if we just have the symptoms that come up in the high top DAT, kind of the places that might be highlighted might be thinking about, okay, internalizing kind of domain is really inside of there, and some detachment. So maybe thinking about exposure and response prevention, perhaps thinking about behavioral activation related to social behavior. So those are the immediate things that come to mind in terms of treatment planning. Now, a lot of the questions that I think that you're asking, which is really about what's going on in the person's context, what's happening in their environment. Based on my own expertise, now this is of course based on one of the clients, or an amalgam of clients I've seen, I should say. Thinking about, all right, if this now was a 24-year-old gay man, thinking about the different questions or information, pieces of information that everybody mentioned in the chat they would want. Is there anything else you'd want to know now? Is there anything more, anything that changes that? Just knowing this is a gay guy coming to you, sexual minority individual. Okay, so Caitlin, again, cultural background, religion, okay. Caitlin, can you tell me a little bit more what you mean by religion? Zachary saying peer acceptance. Okay, so family context for religion. Any trauma history, great. Recent discrimination experience is traumatic, right? Risk assessment, good. Yeah. Their own belief system, right? Okay, so family context perhaps with religious kind of values, but they're how maybe they experience, or if they experience at all, any kind of religious affiliation at the moment. It's social anxiety specifically linked to what others will think of the sexuality. Context of discrimination and oppression. Thanks, Jen. I actually like that one. That may be a big question. Is social anxiety really about, sexual orientation specifically? What if this is a person, and let me even nuance it a little, or query it a little bit more. Let's say this is a gay man living in a very liberal place. Let's say he's living in New York City, in Manhattan, and this is still something coming up. How would we think about that idea, about concerns about his sexuality? Who's very out, who lives in an area where he's out to family and friends, they're all accepting, and yet still, this is still a profile we're seeing. Does that change any more about those concerns about his sexuality, or how you think about that, or what might be coming up? Okay, so Sean's saying it could be a factor, but it sounds like there are other situational issues that are happening. Okay. Potential for internalized messages related to sexuality. Thank you, Lauren. I think that's one that I'll kind of probably jump on in a little bit and talk some more about. Right, perfect. Okay. Oh, where did my cursor go? There we go. Has there been a recent breakup? Internalized messages. Great. These are all really great things to be thinking about. Feeling like they don't belong to the gay community. Thank you for Firas, and I hope I pronounced your name correctly. One thing that comes to mind when I think through this profile, or this kind of profile, I'm even thinking a step up. So I'm kind of thinking this general psychopathology kind of domain. And the reason I think through this is, as many of y'all have pointed out, which I really appreciate, thank you all so much for being so participatory. The psychiatric or the psychosocial domains of dysfunction that many SGM, sexual and gender minority folks experience, are really tightly knitted together. And there is some research, and some of my own research right now has been looking at how some of the behaviors and the indicators we use for some of these domains of dysfunction might not map on, I'm pointing at my other screen, sorry, in the same way for heterosexual versus sexual minority folks. So in this kind of case, that social withdrawal aspect, I often think to myself is that might lead to an elevation of detachment domain, but is it a lack of interest in activities or relationships? Or is there something else? Is this related more to this kind of mixture of relationship insecurity, social anxiety, and really a maybe general psychopathology, or I would even go along the internalizing domain here, really this anxiousness that's bleeding into all these different domains. So again, understanding the context, understanding that, yeah, this might be somebody who is existing in a very liberal, a very accepting community, and still, by virtue of being a stigmatized or coming from a marginalized group, might have processes of related to like internalizing these messages that are from historical accounts that could still impact many of these pieces. The ability to, for example, operate functionally in relationships. So an example that comes up is usually assertiveness, and I have a slide that shows some of these domains related to a history of kind of being in the closet, hiding one's sexual orientation. Even for folks who are out of the closet, there's usually a time of recognition that because of the way our society is structured, something about me is wrong. If I share that, it means some negative thing is going to happen. And there might be this habitual way of learning to self-silence. And then learning to self-silence can bleed across in many of these domains, which could bleed into withdrawal from social activities, out of maybe a concern about anxiousness, about rejection, about all these pieces, and internalizing societal messages about them. Okay, so considering the context of stigma, that many SGM folks exhibit, I would question the detachment domain as opposed to internalizing, as I kind of mentioned a little bit before. A question of, is it lacking interest in activities or relationships, or more an issue of avoiding negative emotions based on histories of rejection? Yes, exposure and response prevention, but something that also comes in is, and maybe falls into that social skills training, which perhaps it might fall into that for antagonistic externalizing, is assertiveness training, is an inability or not knowing how to get one's needs met in a manner that's actually functional, rather than having to continuously hide because of concerns of rejection. And another piece that comes up, again, is thinking about exposure and any kind of response prevention is the reality. I think many times our, at least CBD kind of models, the idea that these thoughts are maladaptive, these thoughts aren't functional, maybe there's too much worry of an outcome that's not likely to happen. But when you're dealing with marginalized folks, the outcomes can very likely happen. So the way we think through them and approach them in the treatment, and even when we get this kind of height up data or any kind of spit out from an assessment profile, it's thinking through what are these other processes that are at the top. How is stigma impacting behavior that's could be fully functional, and then using that to understand what this client might need or how it might be helpful for treatment. So I mentioned that being fully functional as a big part of what I've been trained in these evidence-based kind of approaches for sexual and gender minority folks is talking about that kind of duality, I guess that dialectic of these behaviors are extremely functional in being protective and yet can be distressing in some context. So figuring out what's the context and using then these same approaches that we already know, but kind of molding them for this population a bit more with an eye to minority stress processes or these structural factors that make this a little bit different. Okay, so that was case one. I think it was relatively straightforward, hopefully. So let's talk about a second one. I think my thought process, this one's a little bit more complex. Again, we have a 30-year-old guy, and this is pretty much the high top kind of spit out looks like. We're high in distress, so, and especially insomnia. So this is somebody who is up all hours of the night, not getting a lot of sleep. Fear, we're seeing social anxiety, again, one of the domains high. Negative emotionalities, affective lability. When I'm upset, I don't think. That's kind of one of the items that's really endorsed a lot. Relationship insecurity again. We're also seeing some indicators of disinhibited externalizing. So this is somebody who's reporting a lot of alcohol use, maybe a lot of drug use. So let's say as an example is, this is somebody who's reporting using substances during sex, perhaps maybe smoking a lot during sex, or feeling they need to be high while they're engaging in sexual behavior. And then again, we're getting this detachment domain, although it seems like in the opposite direction as the previous case. Things like exhibitionism, I know how to use my looks. Romantic disinterest, they're low on that T-score, so kind of the opposite. I'm always thinking about sex might be something this person reports. So again, I guess what comes up from an immediate just having this information, what are the type of things you think, or the type of domains that you might think about, or maybe even the immediate thoughts about, all right, I might need to think of certain types of intervention approaches for this person. So I'm going to put it back onto you all again, please. Or even more information you might want. So trauma history, okay, maybe history of sexual abuse. Trauma history, this is coming up, all right. Okay, adult attachment side, thanks, Opal. So Sean's saying the relationship insecurity and romantic disinterest and effective liability along with substitutes. Sounds like romantic avoidance. So yeah, I think that's a good discussion. Drinking or using substances to cope with distressing, internalizing symptoms. Yeah, okay. Attachment by trauma history, using substances as a way to avoid traumatic re-experiencing. So a question that's coming to mind based on these responses. So Sean, Caitlin, I think Claire, hold on, your name's a little bit reduced, so I can't see the full name. But it sounds, help me understand the way y'all are thinking through substance use. Because I have it listed under disinhibited externalizing, but are y'all thinking of it as a kind of propensity to be disinhibited, like this intra-individual disinhibition, sensation seeking, impulsivity, or are y'all thinking of it differently? Think of it as a method of coping with internalizing symptoms. Thanks, Jen. So right, seeing substance use, especially in the context of the symptoms listed, as a coping mechanism for difficult thoughts or feelings. Okay, this is great. Thank you. possibly as a numbing or for dissociation, as for numbing or dissociation, sorry. More internalizing a way to cope or reduce negative emotions. Yeah, okay, y'all are actually making my job pretty easy. So that's kind of one of the thought process I was thinking through a lot. Because this is something that quite often comes up with sexual and gender minority folks, especially sexual minority men I've worked with. You know, based on this profile, you might think of these kind of ERP, motivational interviewing techniques, behavioral activation, and I still think these are all going to be pretty helpful. Now, of course, we kind of see what this is going to go. If this is a gay man, we're thinking through how does maybe all of this change. I think y'all were already kind of going with that idea and that example, how we're thinking through these spectra. So here's how I would think through something like this. And again, what I would say is, I see a lot of connections that y'all have been making between like this distress and fear, negative emotionality, and then disinhibited externalizing and detachment. And again, what comes to my mind is this internalizing way of coping, as opposed to necessarily thinking of it as an indicator of this intra-individual propensity to act in this dysregulated, impulsive type of way. Knowing that for many sexual and gender minority folks, rejection is a constant kind of process that kind of fills in there, the potential for the rejection or the perception that one might be rejected comes in. So social anxiety, the detachment piece, I'm always thinking about sex. I know how to use my looks. I think absolutely one might think about, trauma history, how that might relate to it. There's some evidence that sexual behavior, especially when thinking about sexual minority men, is sometimes used as a way of regulating emotions, and is sometimes in a way propagated somewhat through the norms within a community. You can also think about substance use behavior and the different norms based on the population. So like historically, safe spaces for sexual minority men and sexual and gender minority folks are usually bars and clubs, places where substance use is much more normative. Whereas for heterosexual and cisgender populations, safe spaces are everywhere. So there is a bit more of that unique association between where folks congregate and the use of substances, whereas it's not always that case, or not as much that case for other populations. So there's even a difference sometimes, and I've been thinking about what the norms are. You can even think of the norms for sexual behavior. So I'm using like the high top kind of data here, but when I think about any other assessment tool, like using the SCID or the SIDP or something like that, items that index impulsivity might be things like how many hookups have you had? Well, what's the right number? It's coming from potentially a very heteronormative, kind of cis-normative perspective, whereas the norms for sexual behavior might be quite different. So there's that piece of maybe not pathologizing things, even though they might strike and be really high on a domain, they might not necessarily for that individual be something that's worth or problematic. At the same time, the sexual behavior can be a way of regulating negative emotions, a way of feeling less rejected or feeling affirmed and validated, and related to social anxiety. Substance use, again, in sexual kind of context, might be related to perceptions or concerns about performance. Again, that kind of negative, that anxiety about rejection based on performance, based on meeting with somebody, just general social anxiety, and might be a group-specific way of learning to cope. So certainly one might think about motivational kind of processes, but one might also have to think about what are the outcomes I can actually think through that are realistic for this person based on the context they're in. And I'll get a little bit more to that. So I see these as much kind of interconnected, and then I might think through, okay, if I know this much information about the person, then I'm gonna maybe use these and use the background knowledge of the context and some knowledge about the communities this person comes from, or the way in which stigma kind of is associated with some of these outcomes, to ask follow-up questions, to kind of interrogate this, as y'all are already suggesting, thinking through, all right, is it this kind of disinhibited behavior, or is that more in response to social anxiety? Is sexual behavior, maybe you might think of it as a trauma response, or is sexual behavior now normative, or even is this an individual who's expressing distress about sexual behavior because of internalizing stigmatized notions about how sex should be, about the sinfulness or immorality of their sexual behavior and their sexual needs? And then that's a whole different piece. So is this person concerned about sex because it's really distressing them that they're sexual? This sexual piece that they really feel like I'm compulsive and I cannot control this? Or is it all these other pieces about internalized stigma, guilt, perhaps having maybe higher sexual needs than is the prototypical way, and then internalizing stigma about what that means, that this person isn't, fulfill our norms. So knowledge about stigma and how it manifests among sexual and gender minority folks can impact interpretation and conceptualization. Thinking about things like sexual compulsivity, it could be related to anxious expectations of avoidance, of rejection. It could also be related to that disinhibition, that kind of peace. Alcohol and drug use norms might differ across populations, and alcohol and drug use might be externalizing, but it also could be cultural norms. So just, some of my own research I've been doing is finding that, yeah, using substances in sexual context seems pretty associated with externalizing, the disinhibited kind of externalizing factor, particularly for heterosexual folks. But we're not seeing that association when we look at sexual minority men. We're not seeing any relation with the exception of methamphetamine use. And that might make sense. It might be that that's a higher bar to cross. Other substance use is a bit more normalized within a community, and maybe the learning mechanisms of how to deal with anxiety is related to the substance use. But when you get to crystal meth, things are a little bit different. Perhaps that's indexing a bit more of these disinhibited kind of propensities. So you can kind of think through that literature about, okay, this person's using poppers, that's really normative and not associated with a lot of negative outcomes. They're using alcohol, okay, that might be a bit more related to anxiety. But this is somebody who's using crystal meth in sexual context, and generally, perhaps I'm talking a bit more on that disinhibited externalizing spectrum. And why does that matter? Going backwards. Because the relative approaches could be particularly different. And the way we kind of approach them, the way we approach maybe in motivational techniques could be inadvertently stigmatizing in some ways. So, we're reflecting and summarizing distress around sex and substance use. We're looking for change talk and listing that, thinking about motivation change. Might say things like your sexual behavior really bothers you. You see a need to change things. We might want to move from, acting on a behavior without, but it means we're trying to move from, acting on that behavior. So maybe thinking through that process. Another question with this in mind, the context might be something I would ask is, well, how does drinking or drug use help? How is this helpful in sexual behavior? And kind of really trying to suss out, is it reducing those negative emotions? Is it helping somebody get out of their head? That's usually often something you see. Get out of my thoughts, get away from just like that. And usually then going down into the thoughts, we're actually getting to distressing thoughts about rejection, about performance, about anxiety. And then remembering also that many SGM folks, or sexual and gender minority folks, are coming in with intense shame about their sexual behavior. So they're not always keenly aware of the nuanced ways in which stigma impacts their behaviors and their sexual needs. So without adding that kind of context, you could miss important ways to normalize experiences, normalizing sexual behavior, normalizing and help people understand this is stressful. There are negatives, but there are also positives, and this might be related to a history of stigma and discrimination. So knowledge about stigma then helps making those associations. So again, this really aligns with that internalizing type of response, I suppose, or intervention response of tracking the antecedents of sexual behavior and substance use, testing those hypotheses, psycho-ed about minority stress processes, and it can help to avoid re-stigmatizing the individual. Also thinking through reality of, well, where can intervention go? And I say this in terms of perhaps the expectation of completely sober sexual behavior, and I use this as an example because this is something quite often comes up a lot in populations I work with, isn't realistic. But we could think of reducing harm instead, and maybe kind of making it so that sexual behavior is more gratifying, but also less harmful or less dangerous in certain ways. Now, if folks are interested, and this is one of the articles that David was sent around, a lot of this is because of my own work experience with Dr. John Pachankis and that group. So I was one of the therapists on this esteem protocol, and it's an intervention based on this minority stress model, understanding how stigma leads to different ways of coping and using that and capitalizing on that context for intervention planning. And a lot of it's based on, the unified protocol, based on these kind of typical CBT approaches, and I think could be applied in many outside of CBT as well. So the processes are pretty much the same, but the way of approaching them shifts a little bit. The language changes a bit. So even when I think of things like acceptance-based type of interventions, which are sometimes used in a way to reduce negative attributions about oneself, to help a person understand perhaps that, you know what, maybe I'm a person who's more labile, who's more tense experience with negative emotions, and I can accept that and still act in value-driven ways. completely helpful. I think I've seen it used very helpful in different programs for different clients. The piece that comes to my mind is the narrative of that is one that it still lies within me. And it's subtle, but when I think about the interventions I use oftentimes, a discussion is usually exploring minority stress processes and thinking through if anybody was in these situations, if anyone had to contend with this level of stigma, how could they not learn to cope in certain ways? It's slightly different in that, yes, there's that acceptance that, okay, you've learned to cope in these ways, but there's adding that piece about learning in response to stigma and functional behavior. So it's not that you're broken, it's not that you're terrible, it's not that, yeah, you might be more emotionally, maybe experience more negative emotions than others, and that's completely functional. It's kept you safe in certain ways, and it's not helpful. And I think those are subtle but fundamental ways of avoiding re-stigmatizing an already marginalized group that's coming in with a narrative that they've heard their entire life. And this is, I'm using SGM, folks, that's my expertise, but you can think of this kind of model of thinking through what are the isms and the structures that impact people and prevent them from accessing or even achieving better mental health. So this is pretty much what the principles look like. The idea is that understanding all these pieces of the minority stress process, help one understand, as you all have already pointed out in the chat, the antecedents to different outcomes, and then kind of nuances how we think about those outcomes and what the different domains they might be indexing. So oftentimes it's couched in HA risk behavior, because that was one of the main outcomes from this study, so it's looking at that. But you can see where depression, anxiety, and substance use are all kind of mixed together and related to similar outcomes. So even the kind of take home I want you to take from this is, I hope it makes sense to it. The way I think through it is, the context really makes a difference, even when we have these domains, and for any assessment approach we use. So we're talking about high top, but if you're not using high top, if you're using more diagnosis specific type of approach, this still counts. This still matters to think through, well, what's the underlying relationship? Before I kind of get to the summary, I suppose. When I think through my own work, I think about the high top model here, and I think about the ways in which being, let's say, a sexual and gender-minded person can really nuance all these different places in the model. And it's a lot of places I see. So when I look at, I think about, as we talked about, this, what we might think of as indicators of disinhibited externalizing. Well, depending on the context, and especially for SGM youth or SGM folks, they might be more related to this internalizing domain. I think about antagonistic behaviors we might think about could be related more to folks, again, antagonism, but also just a lack of ability and lack of assertiveness and knowing how to get one's needs met. I think about some of these internalizing types of processes, like negative relationships, fragility, vulnerability issues, and thinking about how stigma relates to them. And in my mind, without that stigma piece or thinking through it, then there might be a difference in how one approaches it and potentially re-stigmatizing a person. I think of norm violations. So if I add in, let's say, I've talked about SGM folks, but you could think about ethno-racial groups as well, like depending on the context. For example, in the US, in the high top DAT, the CAT PD, there are like norm violations. So for example, things about getting in trouble with the law. I am a law-abiding citizen. I respect authority. Well, these are outcomes that might have nothing to do with psychopathology, but are more likely to be endorsed based on just situations, based on things like racism. So again, thinking through the context more and more. Thinking about passivity, I have it here, as a form of detachment versus a form of anxiety and related to that internalizing domain. So when I come down to takeaways, what I hope this would help with, and happy to go into questions afterwards, is the high top model doesn't replace the need for baseline cultural competence and cultural humility. The model itself is a tool to help us understand how typical behavioral indicators tend to associate. But context has to be appreciated for interpretability and intervention planning when using the model, particularly for folks that depart from the norm from which the evidence was built, which is any groups that are not in the dominant kind of groupings in society. As it stands, the model largely reflects behavioral co-occurrence for more dominant social groups. And I think we need more researchers, and more research is underway to help with the applicability and nuance for underrepresented groups. And then keep context in the back of your mind with all assessment modalities. What I hope this doesn't suggest is that it's not useful for diverse clients. I don't think that at all. I think it's actually very useful when combined with context and cultural knowledge. And just thinking through these domains, I might think through, okay, these indicators, if I see this behavior, I might immediately think, all right, negative activity. I might think internalizing, I might think externalizing. And then we just do follow-ups. We just kind of test and get more information to kind of make these differential hypotheses across the board and figure out the best mode of treatment plan. So that kind of brings me to the end of what I plan to talk about. So I'm going to open up any questions or thoughts. I hope that was helpful in kind of just describing how I think through the high-top model and working with the type of clients I typically see for whom structural and social processes are really important to understand and sometimes not easily represented or as well represented in the treatment literature. I sent the Esteem article to David, so he'll send that across to you. It's a good read. And I think it really summarizes a lot of the evidence, the backbone of a lot of evidence-based interventions for at least LGBT folks. I will say it's been very helpful thinking through that framework because it also, you can think of it for many other social structures like poverty, like racism, like all these things. And we have some evidence like from that Esteem trial that the model actually is particularly, the therapy based on that model is particularly helpful for, you know, racialized folks, so our Black and Latino guys compared to, it's helpful for our non-Hispanic white guys as well, but very, very helpful, particularly for Black and Latino and sexual minority men. That's hopefully paper's going to be accepted soon. Yeah, thanks, Stephanie. About that the cultural, the subtle but fundamental shifts. I think of it in terms of a lot of work I do right now, thinking through like borderline personality disorder. I think because it's a really good illustration. And I think through just the narrative of like personality disorders, sometimes being like personality being inherent to the person rather than, well, these outcomes are very much learned. Well, you can argue that. And that narrative, because a lot of the clients, friends, colleagues, and I see will get that diagnosis because XGM folks often get that BPD diagnosis, but then they're coming in with this attributions that something about me is really bad. I have this flawed personality. I haven't had the developmental process. And the narrative in personality literature is often that personality disorders arise because of and I'm using PDs, but I would argue this applies to any of these domains, arise because of a discrepancy in the normal development process. That assumes that psychosocial stress is randomly assigned across the population. But what happens when the environment does not allow this normal development process for specific groups? And that's the kind of thing I keep in the back of my mind. Oh, I see a question in the Q&A. So William's asking about the high-top SR. Is the team taking steps to collect appropriately representative notes of data? How are they planning to evaluate validity and fairness of the test groups? This is a great question, William. So for which phase is data collection in right now? 2, 3, it's ended phase 2. Okay.
Yeah, end of phase 2.
Yeah, we do have a plan in place. So members of the high-top DEI work group have a plan in place, and we kind of put together a plan for testing out the model in different ways, like invariance across different groups. I know there are also some of a couple of folks in the work group who are testing, who have gotten some grant funding to actually support testing the model, like a translation in Spanish and for Latino populations, to kind of look at these. So it's an ongoing idea we think through quite a bit. And even the knowledge kind of going into the model. So for example, I worked quite a bit with Dr. Mullen Sweat for the externalizing kind of items when we were thinking through like sexual compulsivity as externalizing and thinking through how the items we use could include bias. So some typical like measures of compulsivity might use items like I have anal sex as an indicator of compulsivity, because the assumption is that's less normative among heterosexual groups, that might even be dated. But you can see how that item might artificially inflate this externalizing domain among, let's say, sexual minority men, for whom that's extremely normative. And there are other items that can be conflated with stigma. So for example, I'm ashamed of my sexual behavior. Yes, that might be because I feel I'm out of control, but for some groups, it might be because my sexual behavior is highly stigmatized. So I think we're thinking about it more and more, and especially if we're working in the DI work group, we're trying to test these out more and more, and trying to put in place a plan for including more of this along the way. My thought is, because of the way we've created the high-top model, it can incorporate a level of pluralism that is not usually incorporated in other types of models. So universality doesn't mean it applies in the exact same way to everyone. It's that we can actually look at this model and find out places where there are the ifs and the buts and the ands for certain groups based on stigma and other pieces. So that's my hope. Sorry, seeing more Q&A questions. Were there additional adaptations made to the UP protocol with esteem outside of the integration of minority stress? If so, might we give a few additional examples of how adjustments were made to better fit? When I think to myself, the big piece is that the minority stress kind of approach for at least the edit to the UP is kind of everywhere in it. So we kind of start with this minority stress discussion and working, like talking about that framework with clients and then thinking through it. But it's always like a lens that colors everything else. So even thinking through, let's say, emotion-driven behaviors, we're thinking of them from a minority perspective and kind of understanding how some of these behaviors, yes, they're in response to negative emotions, but also how in the past they might have kept a person safe, from avoiding rejection, from avoiding discrimination, from avoiding violence, and how, given the context now, they're more might not be as effective. There have been one of the I think big maybe adjustments has been explicitly including assertiveness training as a module, because it's something that's so often an intervention focus point for SGM populations. I think like especially much more discussion about sex and that sexuality and how sexuality is stigmatized, taking a much more sex positive approach. So that's much more infused within it, but also thinking through how minority stress processes kind of are propagated from within the community as well, from these internalizing these negative messages, but also showing how stress is from within the community, that, you know, and helping people understand that, for example, from like racism within sexual minority spaces, or classism, where it's difficult for folks from poverty, different pieces like that. So I think it's really infused throughout. Yeah, and it's just, I think, a framework for thinking through them. Where are we on time? Sorry.
We still have time for more questions if there are more questions. So I have a question if no one else does now. There's actually a question from one of my students who asked yesterday, Charlie Sue asked about cultural factors like actually within the model of high top. So I'd be curious what you think, and whether, so his question was basically like, is there room in the model for cultural factors? So not necessarily like cultural expressions of psychopathology, but, you know, actual experiences of discrimination and family factors that might vary by cultures and things like that.
I think there is. I think so. The people we're writing right now, actually, and hopefully finishing up soon, is that making that exact argument that the high top model can accommodate this level of pluralism. You can think of looking at the high top model itself and then adding this layer above it, or maybe even a lens that just changes how you think through some of these domains. So I might think through things like, let me think. I'm thinking of culture in terms of, you know, I come from the Caribbean, thinking in terms of what's normative socially and social norms around like community and family and things that might maybe load on that detachment domain, which might look different based on groups, which doesn't necessarily mean pathology, but just different based on the populations you work with. The way I think through it is coming back to always thinking this is a model. Just like the DSM, these are all models that are supposed to help simplify things, but are never going to work perfectly for every single individual, but they can give us some hypotheses. So the adding in, or maybe it's the expertise of working with SGM populations just helps me think through, because how I think through it here, all these different factors could impact different places in the model. So I might think of it in other ways, like how does racism impact what I'm thinking of as externalizing, or other pieces, or things like even antagonism. You can think of what we might consider aggression and how that gets viewed differently based on somebody's ethno-racial background, in the US at least. You can think about things like somatoform, perhaps, maybe how people express psychopathology. I think like in the Caribbean, where the expression might be have a headache, maybe more these physical kind of ailments, and the language around mental health isn't the same, so it might manifest differently. But understanding that then helps you think through, is this a somatic complaint, or is this just the language that folks are using? And then gives you some ideas of, okay, I might want to ask more questions, or I want to just, you know, test things out a little bit more. So I don't know if that helps kind of answer the question.
Yeah. Thank you.
I don't know if there were other questions that even came up yesterday. Yeah. Sorry.
Are there other questions that anyone has?
So Caitlin's saying that she's been using Caitlin's been using the cultural formulation interview for the DSM to explore cultural and individual context factors that are influencing clients. Are there other suggestions to assess these contexts? Or how might an interview being developed to incorporate cultural sensitivity? Yeah, I remember where I was before on postdoc, we were having some of these discussions. The tough piece about some of this is it really depends on the context. So, I think about racism and how like ethno-racial groups are, but that's really contextually based in the US. When I think about back home in Trinidad and Tobago where I'm from, it's slightly different. There are some similarities based on our own colonial histories and all these kind of things. But when you think of who the populations are and how people are racialized, it looks a little bit different. So I see that might be a little challenging in some ways. I think the thing that comes to mind is that cultural humility piece and kind of being aware. I don't know if any of us can ever have all the knowledge in every single population group. That would be difficult to have. But we can be aware of our own, to an extent that I don't belong to certain groups. I don't know what this experience is like. And I can use that and use some of the knowledge about some of the scholarship about some populations to kind of guide questions, but also just to remain humble and working with the client to kind of figure that out based on their framework and letting them kind of lead that description. But it could be used to add your own hypothesis about what I might follow up and ask more questions about or try to understand. I wish I had a better answer for that, but that's how I make sense of it right now, at least. Oh, what are the general demographic breakdown within the samples the height-up model was known? So in terms of the height-up model, it really depends. So we've used, and I think the height-up consortium has really tried to use a lot of population-based samples. So it's big samples across many different countries. So you can think about, yeah, there's a lot of cross-national generalizability. What you need then when using these big population-based samples, for example, the majority is going to be like heterosexual cisgender folks. So you kind of need these targeted ways of looking at other groups, which again, I want to say this is not unique to high top in any way. This is clinical kind of psychology specifically. David, I think you wanted to answer the question or?
Oh, no, I was just indicating that you were answering it live.
Oh, I had no idea what these things look like. Okay, cool. Yeah, so that's how I think through it. And I think it's just being open to actually looking at different things and including more scholars and more folks with that with different types of expertise and different ways of looking at things will be helpful. So I don't think it's terrible. I think that's just how our science does propagate. I think there are ways we can improve it. But I think the high-top model is uniquely positioned in that because it's built in a way and because we have a strong revisions process, all these things to actually incorporate new evidence, it's built in a way that can actually accommodate a level of pluralism more easily than maybe other models. Firas is asking, do you think contextualizing patients' complaints runs the risk of fostering contempt towards their communities? Just thinking about alcohol use, substance use, and exhibitionism being infused into the queer community. Yes, I think it's being very careful. So these examples I use, even when I'm saying them, I'm like, I hope this is based on like different parts of research. So I hope we're not thinking this applies a broadband to everyone, but it's kind of using these as hypotheses, thinking like, okay, and other pieces of hypotheses. For example, I might think through, okay, what are the other social contexts that, let's say any sexual minority person I'm working with is involved in that might give me more information? What kinds of, let's say, clubs and parties are they going to? That would tell me more information because I would think about what types of substances might be more normative in certain domains. So there's always that careful piece of not, what's the word I want? Generalizing too far and then being careful. So it's understanding how stigma impacts communities and how that might be related to specific behavioral manifestations about communities, but not reducing communities to those things at all. Just using the hypothesis driving. So that's how I think through it based on Firas's question. Heather, you talked about this in the beginning. I'm worried that the data we are gathering from clients, I'm guessing, is using assessments that are not normal and inclusive populations. So can we assume that the high top is valid for BIPOC by neurodivergent clients? I suppose to a large degree, I do take that assumption. And the bias I have is I am somebody who, scientific career has been within the high top domain and in the SGM domain. So I kind of just see them as very complementary. When I think about how, because when I think about like, let's say SGM populations, well, we know that a lot of the psychosocial stressors or psychosocial problems or dysfunction are all kind of housed together much more tightly. So it kind of maps onto these high top way of thinking about, oh, there are things underneath these individual disorder domains. So that's how I think through them. Whether or not it's valid, I wouldn't, I don't know if I'd go so far as to say it's invalid. I would say, as with any model, the model is based on dominant groups. I think there are some universal pieces that can generalize, and then I think through that there are some pieces that I would be a bit more hesitant to think through, or I would think about the context a bit more, or kind of add maybe some nuance based on that knowledge base. So what I come back to is any model is not going to apply to everyone. And I don't mean that to excuse how our research propagates for dominant groups alone. But keeping that in mind then helps me kind of say like, all right, this is just a model. I can use this model and make sense of it, but I can add my expertise and my thinking about underrepresented groups and kind of think about how I would think through where this impacts the model. And hopefully the whole reason we have the DEI work group is to include more of this and thinking, we're having a lot of conversation about thinking through, all right, what do we need to do? What is the kind of research we need to be looking at? Some of my own research is looking at how some of these indicators work differently based on, let's say, queer status, to be quite frank, versus not. And finally, there are some interesting differences. And there are some important things to think through. And it aligns with a lot of the treatment literature as well. So I feel like that's my way of thinking through it. And it's not the ideal resolution either. That was in response to Heather's question. Oh yeah, and Stephanie just included a really great link, some really great stuff about cultural humility, which I might steal for my intervention class, grad class next year. So that'll be good. Oh, I think Opal, how might yeah, okay. So I think we talked about the interview being developed in corporate cultural sensitivity. The part that feels challenging to me is about an interview. It's that's why I was hoping for that intersectionality video to play. It's a way of thinking through. It's kind of a framework that colors everything you do. And so, you know, if you're reading on intersectionality and intersectionality theory really helps because it's a critical way of just thinking through the isms and the structures that impact how folks are treated and their access to different opportunities and resources. And then that impacts how you think through this. So I almost feel, and this is just my personal feeling, somewhat hesitant of like, I don't know if I could ever think of a proper, you know, be all end all cultural sensitivity assessment because it really varies by the situation, the place, the time, and all these other pieces. Jen saying, do you have suggestions about how a clinician might weave culture into the feedback given the client? Yeah, based on hydro conceptualization. I do actually. And I think of this in how I approach it from a more diagnosis specific manner sometimes. So as somebody who's trained, I suppose, in high top, my bias is like, all right, I don't, you know, the diagnoses don't mean that much. It's all what's underneath them. So I'm always hesitant to be like, if somebody doesn't ask, like, if somebody wants a diagnosis, I'm always framing this in terms of what you need criteria for, but also relating it to what the person is experiencing. So, all right, you need criteria, let's say for, I don't know, if I had to do it, borderline personality disorder, for example. Well, this makes sense. You're telling me about this intense anxiety when you're in interpersonal relationships and these fears of rejection. And we've talked about this history of being rejected from family, growing up in a very religious population. So it makes sense that this is something you're struggling with now. You talk about, you know, things that might map onto impulsivity. You talk about, you know, acting maybe sexually when you're feeling very dysregulated or emotional. Well, yeah, okay, that also makes sense about like learning ways of coping with stigma, substance use in response, identity disturbance, whatever we want to call it, is extremely normative because of always living and having to conceal a stigma. So you can think about relating those to the context, if one had to, because there is the difficulties. I know some folks find power in getting a diagnosis and feel, and again, shifting that attribution of it's me to there is something that helps explain this, or even talking about these domains in the same way. But then talking about, it always kind of lead to talking about what this means. It doesn't mean this is like a death sentence. It doesn't mean this is something that somebody's going to be struggling with forever. What it might instead mean is, all right, if I'm talking about BPD, for example, well, I know the literature that folks resolve over time mostly. So talking about all these domains, it might be like, this doesn't mean that this is something that you're always going to be dealing with. It might be a predisposition to respond in a certain way, but it also might be that as we work more, this might go down. So I feel like instilling that hope, and especially if it makes sense, that it's framed. Oh yes, sorry, Caitlin, that's actually a really good one. I'm going to come to that. If it's framed in terms of kind of learning, the piece I always use is that, and I often use this exact statement with like estrogen cancers. Usually, I usually work with young adults, so it's usually they're coming in like mid-20s, 30s, and it's, which I guess maybe is not young anymore. The idea is, well, after we've understood a little bit more of this minority stress process, well, you've learned to adapt in this way. It's been functional in some ways, it's not helpful in some ways. What it tells us is we can learn to change, but it's going to take time. We're going up against 25 years of being one way that's been helpful. It's going to take us some time, but there's a hope there because these are learned ways of coping rather than something about you as a person. So I guess, Caitlin, but you might meet criteria for X, Y, or Z, but I'm less concerned about the labels. I'm more concerned about how it shows up for you in your life. Yes, I think that matches really well. Because for some folks it's helpful. For some folks, having a diagnosis connects into community, having a diagnosis connects into different things. I've also seen the opposite where a name can also, depending on where they go, like, TikTok therapy, what they might get sometimes are things that are just more stigmatizing and inaccurate as well. So it's this uncomfortable balance sometimes that I have to kind of tread about, well, what's going to be helpful? I don't want to re-stigmatize somebody for something that could be helpful to them. So I don't have like definite suggestion about what you should or shouldn't do. It's more like it depends on the person. Like, yeah, I agree. Mid-30s is totally young. And then I realized nobody in my undergrad class knows what Golden Girls is when I pull up a clip to show them. So, yeah.
And if there are no other questions about this presentation, we also had some time reserved at the end for questions about, high top in general or about anything that we've covered in the last 2 days. I also wanted to talk a little bit about some kind of housekeeping things. So it's come up on the chat a couple of times where people have asked for links to the articles that have been referenced and presentations. So I will send that out. I've linked some of them in the chat, but I'll send them out as a PDF over email too. And on that note, if you haven't gotten emails from me, please let me know, because there are some that are bouncing back because they're undeliverable and it's not completely clear why that is. So there may be kind of errors in email addresses. Are there any questions or anything about the kind of the broader workshop in general?
David, can I use this as a time to also just plug that if folks saw this on Twitter or social media, I'm not sure how everyone found out about the workshop, but if you are a clinician and you're interested in being in the High Top Clinician Network, at this point right now, all you get is a couple of emails from me a year, probably no more than like 4 or 5, that gives updates on High Top. We're aware that not everyone has subscriptions to the journals that High Top is publishing in, so we try to provide you with information about things that are ongoing, and I can put in the link the Clinician Network sign up page. You'll probably, there'll be a short delay. Usually I do them in batches. So when you join the network, sometimes you may get an email the next day. Sometimes it might be, 8 weeks or so before you get the email, because I just group them all together. I'll get that link for you.
And also thank you to everyone who did the pre-workshop survey yesterday. I am going to send out another link to a post-workshop survey, and I'd appreciate if everyone can fill that out too. We're particularly interested, there's an open-ended question at the end for comments, and we're particularly interested in what you liked and what you thought we could do better, so that we can improve this training moving forward and the workshop moving forward.
So there's another question in the Q&A from William about the ITOP SR and describing like plans for normative data collection, like target sample size, sample composition, demographics, etc. I know a little less about that. I'm not directly in the measurement work group, so I'll defer to either David or Stephanie as to what the upcoming plans might be.
And I was involved in phase 1, but I haven't been as involved in phase 2. I don't know if you might know more, Stephanie.
I know that phase 2 is wrapping up data collection. Right now, I think that the goal is to finish analyses by December. So I think there have been a number of different data collections. So a lot of undergraduate samples, as is probably not surprising to most of the folks on this call, as well as some convenience community samples using either MTurk or Prolific. David has some really great clinical data, and I think that Roman also had clinical data from Stony Brook. But I think our goal sort of next also is making this a useful tool. So we will be collecting data for not only norms, but also making it shorter, making this more clinically useful, like working on that modular component that Roman was sort of mentioning before, that maybe you don't need you don't want to assess for the full model, but you only want to assess certain spectra or pieces of that. And so I don't have a great sense of what that data collection is going to look like at this time, but I think that will be phase 3 of high-top SR. Craig, I laughed because you missed right before you came on the call. Someone had a question, and I was like, I think we're on phase 2, maybe phase 2B. So I had sort of the same reaction you did.
Yeah,
it's been ongoing.
So I guess to answer the question, what I'm hearing then is, and maybe this might be something Len can answer more, is that there isn't, like right now, right now it's finishing the data collection and finishing the initial analyses. And I suppose what I hope is in the future then thinking through more and finding, I think that's a chance for all of us, is finding more diverse samples as well, to look into how, that's definitely what I'm invested in thinking through, especially with the DEI work group, is how can we test this out and test out, where the model works, where it doesn't work, if there are any differences based on many different pieces. And that's the hard part, is okay, there are many different avenues one could look at. Yeah, so it's like some of my own work has been thinking through, can I add aspects of the high top model that are appropriate for the population I think about and might be related to kind of nuance in the model? Because as Stephanie's saying, I don't think I'm going to want to assess the whole model of SGM folks, because I think through things like somatoform, maybe based on the samples I'm using, aren't going to be as interesting or as pertinent. So I'm going to kind of pull the ones I think are really going to be where I find nuance and complexities that I'm going to look through. But that's just ideas for future right now.
Yeah, and also with making the high top SR freely available, we're hoping that people will use it broadly and will be able to learn from others' research as well.
Yeah, I know that there definitely have been a lot of discussions about getting more clinically useful data, as well as more reaching out to other samples and populations. Part of it has been a funding issue. Much of the high top research that has been conducted is entirely from, our own like small research slush funds at universities. Len Sims is a great person to ask a lot of these questions. He's the director of the assessment, all the assessment work, the measure development work group. And he does have a grant, which is being used for high top measure development, which does include some money for samples, but that I think is really the only, to my knowledge, it's the only high top grant that has been funded. And so it takes a while to get beyond these really basic convenience undergraduate and community samples. And
I know I talked about like the what kind of samples go into the high top model. A piece of that is also that the challenges that, like for example, in SGM research, the difficulty I've had is that a lot of the data that's been collected on these samples doesn't have the breadth of psychopathology for us to do any of this. It's usually very limited in the type of psychopathology data we need to actually investigate this. So it's kind of like, but then a lot of like the psychopathology rich samples don't have many SGN clients. So these kind of things all come together. And it's kind of like right now building that infrastructure or thinking through that infrastructure to get more of these diverse samples as well. Because the norms in like LGBT kind of research isn't so much the breadth of psychopathology that we tend to use here.
And I know I'm joining the tail end, but that's grant that Len Sims has. For example, we have a supplement where we're collecting data in the Rio Grande Valley, translating all the high top SR into Spanish, doing multi-stage translation effort. But those are early days, and that's still months away before we have those kind of instruments.
There was a question in the Q&A about whether we think the PAI is as good of or is a good high top tool. I would say that I think pretty highly of the PAI. We use it in our clinic at UNT, and it's very consistent with the high top model. I don't know if others want to add to that as well.
Yeah, I know Chris mentioned in answering another question earlier that he also would use the PAI. We like the PAI. We use it in our clinic as well. It is a little bit more focused on sort of the lower parts of the model. So you may not get some of the overarching like spectra, like disinhibited externalizing. And as a general adaptive personality, folks, it would be missing a bit of that. But I think the PAI is a super solid measure.
There's a question from anonymous attendee. For getting psychiatrists more involved, can the high top DAT be incorporated into medical record software like Epic? What would the barriers and next steps for that be?
Well, I know that I can't answer that question directly about that software. I think that Catherine Jonas works in a psychiatry department and so I encourage you to email Catherine Jonas. If you'd like to start using the high top DAT, she will work with you to get it incorporated into your clinic. And I know that different sites use different software when they're using that battery. So I can't answer for sure. I don't know if Stephanie or David, if you guys have a better answer to that. But I know Catherine is eager to get the high top DAT to you. So I encourage you to reach out to her or to reach out to Roman Kotov. He's also eager to get that out to you.
And I don't know if this helps or not because I'm not that familiar with Epic, but we do have versions in RedCap and in Qualtrics. So I don't know if that helps or not.
I don't know if David or Camilo had a good answer about the measure in children and adolescents, but I do know there's a newer high top work group focused on development and children and adolescents. I believe Celia Wilson, Kevin King, and Mike Hallquist are some folks who are working with that work group. So part of it's like developmental processes and things like that. But my understanding is that there will be some connection between the measure development group and the development work group to begin translating the measure into more sort of like child and adolescent constructs as well.
And Brady Nelson, who presented yesterday, is also. And
I almost said Brady, and I was like, is that right?
Well, if there are no more questions, then as I mentioned a few minutes ago, please be on the lookout for an email from me that has some of the resources that we talked about, and also a link to the post-workshop questionnaire. And if you have any questions, you can reach out to any of us. I'll include in that email all of our contact information, although we're all easy to find on Google as well. It looks like there may be another question coming through on the chat. So there's I think a comment about the spectra indices of psychopathology that is a brief and report, and David says that it's good. Okay, there's another question on the Q&A. Could statistically sensitive screening questions be utilized to save patients time when completing high top? So that's also something we've been thinking a lot about. And Stephanie, do you want? Okay, and I know that there are plans to create screening measures based on the high top SR2. Those are still in the really early phases of development, though. But ideally, we would have these shorter measures that can be used for for screening and other situations in which it's not practical to do the full high top SR. We're also working on things like cutoff scores and, which is somewhat doesn't necessarily fit that well with the high top model, but would be, really useful in practice. Okay, well, with that, then please be on the lookout for the email, and thank you to all the presenters. I'm really happy with how everything went. I think it was a really good workshop. So thank you, everyone.